beginning of the Nuffield report, they list the challenges facing emergency surgery, and a lot of these are familiar, and it's very easy to skim over them because you've read them hundreds of times before. The key one for me is the variation in outcomes, and again, we've seen a lot of data with regard to that today, because when we see variation, the inference has to be that we're missing an opportunity to achieve high quality. Workforce challenges, increasing numbers of patients, these are common themes. Organisational and operational challenges, these are common themes. And tucked away at the bottom of that sentence with a small c is contracting. Now, this, to my mind, as I'll go into later, is a very important issue because this means the money in terms of delivering these improvements in our quality of our service in emergency surgery. And it's this where I think the biggest barriers, certainly England, are presented to us. And we're going to need to do more of it because we've got an ageing population. So this report is about solutions, and the Nuffield group present them in 4 major areas. Systematic use of protocols and pathways. Again, if we think back to Ian Anderson's talk today and other talks in terms of improving emergency laparotomy outcome, these protocols and pathways are worthy of serious consideration. They suggest the moving towards network-based approaches to delivering these services and the development of non-medical roles, nurse practitioners and physician assistants. Now, I apologise in advance, I'm not going to have time to focus on this area of practice today. And I'll finish up with talking about the other end of the debate, which is that of new training models. And the real crux of the question here is, what is the role in our country for EGS specialised surgeons, in whatever guise and in whatever model? So this is a figure taken directly from the document, and there's a lot going on here, clearly. But if you look on the left side, you'll recognise those 4 key areas to target for improvement. So what do I think about those to start off before we go through them in turn? Well, the protocols and pathways you can see listed there, the Help Quick bundle, this is bundling of care, this is achieving quality, getting patients assessed quickly, getting them CT'd quickly, getting them a decision made by a senior person, getting the right people at their operation, and then getting them to the right post-operative care. And we all know, and especially been a reinforced argument today, that if you do that, you can expect an improvement in your emergency laparotomy mortality outcomes. How can you achieve some of these things on the way? Ambulatory care pathways, direct telephone access, and we'll go into these more in the future. So networks, new roles, new models of training, these are important, but I'm going to focus first of all on what I feel is the most important part of the report, which is the protocols and pathways. This slide we've seen earlier today. This is 3 years of data from the first years of the National Emergency Laparotomy Audit. And what does it show? It shows quite significant variation between units in terms of achieving mortality outcomes. Now, we've also heard this is not risk-adjusted data. We don't know which centres are risk-averse in terms of not operating on high-risk patients to protect outcomes. These things may or may not be happening. But what we're inferring from this is the centres with inferior outcomes are not operating best practice, and there has been some data presented today that demonstrates that may be the case. The next question we have to ask ourselves, because as professionals it's our duty to always be seeking improvement. There is never a situation where you can say anything is acceptable in my view. You should always seek to minimise until your mortality is 0. Now, you'll never get there, by the way, but that's what you should try and do. So the next question to me is the best performing centre in the UK good enough? And my colleague Ravi Vera presented some very interesting data comparing 5 years of data from administrative databases, comparing, it's England rather than the UK, my apologies, with New York City. Now, this is NYC metropolitan area, an insured population, but a population for which, during that time period, in order for the institution to be paid for the care they deliver, they had to institute pretty much all of the factors that are recommended by the Nuffield report and more, i.e. all patients have a consultant or an attending their operation. All patients go to ITU afterwards. Now, of course, 25% of bed stock in the US is critical care, and we may not be able to match that, but that's what they do, and they're the outcomes that they get in the New York City area, or what they report, and that's about a 6% mortality rate from all comers. So can we achieve that in the UK? Well, Huddersfield have, and that's why they've won the Naylor presentation prize with a mortality in their new group instituting these measures of 6%. I'd like to step out at this point to talk a little bit about Nottingham. Now, I recognise that there are lots of high-performing centres producing high-quality data, and this is just another example, and maybe not as good, but it's my experience, and I'm going to use it to highlight the changes that we've made and the barriers that we've faced. So at the time of my becoming involved with this situation, which was as a senior registrar, trying to get involved in health service improvement projects, some service design had occurred. The Queen's Medical Centre in Nottingham had become a level 1 major trauma centre. We'd instituted CQueen measures, which are very much like the ELP-Quick bundling of care. The anaesthetist had been busy and put on an anaesthetic consultant coordinator, which had improved our access to theatres and improved efficiency. And the concept of running a surgical triage unit or ambulatory model was coming into play. So essentially we had an ELP-Quick bundle and we had improved access to theatres, and we were focusing on the other bits in between. The drivers with change have been echoed throughout many presentations today. Long waits, too many patients, not enough doctors, bad processes. And some of these in Nottingham stemmed from our complete open front door model of unquestioned admission. So we got a lot of inappropriate referrals, and we had no way of getting people through systems to decisions quickly. So we changed along the lines of the Derby model and others. We've instituted an outpatient facility with reception rooms, waiting room, we've got triage rooms, and of course also imaging. We were able to get rapid access blood tests, and we've got up to 12 scan slots a day. And key, no beds, and I think that point's been made quite clearly today. This is our model. A phone call comes through to a single phone, so it's a single point of access, answered 24 hours a day. The person on the end of that phone, who is a consultant surgeon between 8 o'clock and 5 o'clock Monday to Friday, or a registrar at night or at weekends, can give advice, can redirect appropriately, and that's an important thing. Redirecting patients is not being work shy. Patients who go to the wrong specialty demonstrably have inferior outcomes, and that's because of factors of the receiving team abdicating responsibility and workforce protection on the part of the team who should be having the patient because they're safely under the control of somebody else. Let's leave them there. If a patient does come to us, and a lot of the time they will, we can then assess them, as I've discussed, and make a decision. And if they have pathology, they come in and they get rapid access to treatment. We also have other outlets such as ambulatory clinics and even re-review mechanisms. Patients like it. Now, I acknowledge that we're coming from a low base. If you put patients on trolleys waiting for many hours to see somebody and then put them in an STU, you expect your complaints to go down, but they really have. We've had an 85% reduction in complaints and really quite marked improvement in our patient experience metrics. It's efficient. Now, Ed, one of our registrars, Ed Hardy, who's, congratulations, he's got an NTN today, so well done to him, has presented this data earlier this afternoon, but you can see that essentially what we've done with the STU part of the model is convert a lot of our one-day stayers into zero-day stayers. So these are patients who didn't need to come in, but it took 24 hours to work them through the system to make that decision. 15% decrease in attendance. As I said, 57% increase in same-day discharge equals a large length of stay reduction. So actually, that's incorrect there. That's a 5-month length of stay reduction, is 2,635 beds. So it's over 5,000 a year, certainly. So you would think that by improving your service efficiency, decreasing unnecessary admissions, decreasing your length of stay, that would just decrease costs to the NHS and everyone would be happy. And indeed, when we work out our numbers, we billed our commissioners £2.1 million less for 2015 compared to 2014. It's safe. We're not sending people home who shouldn't be going home. And as an indicator of a part of the service, in addition to the important other factors which allow me to say that I think we're fulfilling all the criteria in terms of protocols and pathways within the Nuffield report, we've seen a year-on-year reduction in our emergency mortality. Now, we're a big centre. If you looked at that mortality plot earlier, we're very much to the right of that. And we're a tertiary referral centre with a high-risk population. So we've got 10% more high-risk patients than the national average and 10% less low-risk patients compared to the national average. So we have our 10.3% is way below our predicted mortality, and we are not satisfied with it and will continue trying to improve it further. So drawing this part of the discussion to a close, the Nuffield protocols and pathways, to me, has an evidence base behind it now which is bordering on irrefutable. It's not acceptable to ignore it. I feel it's time for our institutions, including this one and the Royal Colleges, to stand up and say that achieving the circumstances set out in this report should be a standard of care, because otherwise you are, without delivering these things, you are accepting an increased mortality that you could reduce. The next question is, are we going far enough, which is what's in Nuffield? As I said, the situation in America is different. It will be difficult to match it, but should that be our aim? Final point is that in England, the finances of this are complicated. I mentioned the £2.1 million, which sounds wonderful, which is why we're going for a Health Service Journal Award next week. But the truth is, the funding arrangements mean that NHS trusts, ours included, are not incentivised financially to make this change. And that's because this contracting area means that when you make these savings, you deliver them to your commissioners in England. You don't deliver them to your trust. And that's an important barrier which we need to overcome. The only way to overcome that is by engaging with commissioners. And unfortunately, they also have to engage back with us, which is not always easy. So coming to the other parts of the report, I'm going to discuss networking, and I'm also going to then discuss the other big topic, which is, in my view, the future of the service. So clinical networking is given quite a lot of credence within this report as being something we should look into formally. We obviously have tertiary referral arrangements already. Major trauma has been a great success in terms of reducing mortality from serious injury by around 20%. And we also have subspecialty relationships in terms of tertiary referral. There's also good national examples of hub and spoke modelling for covering different types of service, including pancreatitis, and there certainly seems to be some mileage in others such as inflammatory bowel disease, interventional radiology, to name a couple. So why would you use a network? In my view, you'd use a network to solve a problem, and that problem is a problem with emergency service deficiency in this context. And again, when you're looking to put a network in, the first thing that might lead you to have those thoughts is evidence of variation. Now, that could be in variation in an outcome, or it could be a variation in delivery of a service. So it would appear to me that, therefore, we're looking for common conditions with an evidence base for an intervention which is either not being done well enough or not being done at all, and also a spectrum of requirement for the patients with that condition, varying from a simple case that can be managed anywhere to one that requires tertiary referral input. So what satisfies the criteria in the context of EGS? Well, the Nuffield report argues, I think successfully, that emergency laparotomy doesn't probably fall under those criteria. The reasons for that is that we have a presumed explanation for poor performance, i.e. we're not doing the packaging, and it's not a service provision issue. There's a very good evidence there that the size of your centre does not relate to your mortality, unlike in elective situations in other diseases. And again, things like appendicitis, abscess drainage, good evidence is being done very well in lots of different contexts, and a network wouldn't apply. One area where I think it would is emergency cholecystectomy. Now, this data I present up here, which I'll go through in a second, is courtesy of the Orgis and Methods Analytics SWORD system, which is the surgical workload and research database. Now, as Ravi Vera spoke about in the health informatics session earlier, we need to be looking more closely at the data that's out there from a national perspective. And at the moment, these administrative databases are amongst the best sources. So this data here, this scatter plot that you can see, a funnel plot, demonstrates from hospital episode statistic data how many patients, in terms of a percentage, presenting to a service with a gallstone code go on to have their gallbladder out within 14 days. And this, is, of course, is a surrogate of compliance with international guidelines that say what we should be doing with these patients, i.e. taking their gallbladders out in certain situations. And you can see that it's a snowstorm of different areas of practice. So we definitely have variation. We have centres that are delivering this service, and we have centres that are not delivering it. And in this context, the service gap equals patient harm. If we've got an international group telling us that we need to take these people's gallbladders out and we don't, we are harming them. So how can networking help? So local networks could be established in centres that are not delivering emergency cholecystectomy. Who have you got that can do it? Get yourselves organised. If you don't, approach your local units, discuss it, form a group, and maybe you'll consider forming a hub and spoke model. There are even ways to assess patients in terms of where they should go in terms of their complexity. It's a nice paper presented at the IHPBA last month looking at the preoperative risk factors for conversion, and this could be used in order to determine which patients you might want to send to a tertiary centre. So finally, I'd like to come on to talk about new models of training. And this is probably one of the biggest hot topics that we have in the specialty at the moment. When we've looked as a group towards the future in the past, it's natural for surgeons to ask, what do we want to do? What kind of job would I like? What do I want to do in the future? What's my 5-year, 10-year plan? And frankly, that's not correct. The question is, what does our population need us to do? Because we are here to serve that population with whatever it requires. And yes, it requires tertiary subspecialty surgery, but it also requires high-quality emergency general surgery, which is just as complex in many cases. And behind all that is, do we need specialists? Do we need to call emergency general surgeons specialists and mean they do only that job? My feeling is there's a balance required here. I present these areas on different sides of the screen, not because they're completely separate, because they're not. There's a lot of agreement across the sides, but in basic terms, we're balancing what we're hearing from our trainees in terms of what they want to do and their concerns about being ultimately placed in jobs that they don't want to do, potentially. If you look at the bottom graph there, it doesn't come up brilliantly, but that little bar graph at the top is a number of people who say they want to do emergency surgery as a pure specialty, and it's around 30 people out of 276. So the majority want to do something else with or without general surgery, and we should listen to that, and it's important. On the other side, we've got the Shape of Training report, which is aimed at the generality of medicine rather than surgery specifically. But again, what's being tried to be achieved here is to match workforce to population need. And in Anderson's report, which I'm sure you've all read many times, gives some very sensible ideas about how we marry the two. And this is what we have to come to. Here are some options for how a career with emergency surgery in it could look. Is it a single choice of you do it or you don't? Or is it a menu of options that individual centres can pick and choose from according to their individual needs? So up in the top, 100% emergency surgery all the time. Is that a job for some people? What trainees are most scared of is a 5-year contract to deliver emergency surgery at CCT and then know where to go afterwards. There are people who have proposed doing emergency surgery heavily at the beginning of your career, tailing it off and stopping halfway through, and you go off to do more important things. Or is there another option? To have a career where you deliver both at different times in different places. That's what we've gone for in Nottingham, and that's what he looks like. And he's sitting in the middle. Okay, so just going to nip out at the moment and talk a little bit about what I feel might be a model for this in the future. And it actually turns out that it mimics the thoughts of the Major Trauma Workforce Sustainability Group at the Royal College of Surgeons of England in how a major trauma thing might work. Now, what that looks like at the left-hand side is a pretty standard training program, and then a proportional amount of emergency general surgery within your job plan. Now, I'm not saying that this is how it should look in terms of percentages, but a differing amount of proportional work done, but with everybody delivering emergency general surgery as part of their job plan. And it could well be that we have a heavy role at the beginning of our careers, use our subspecialty skills when they're at their highest in middle career, and then increase the proportion of emergency surgery again in later career when mentorship roles are so important. So that's what I think. If we substitute MT for there, that might be a way forward. So to finish off, What do we need to do? I think we need to change our culture within surgery, and it's so nice to see so many people come here to hear that message. But essentially, we need to embrace a whole specialty responsibility ethos, in my view. Emergency general surgery is hampered at the moment by the value and respect afforded it by the profession. The mode and model and examples of its success and a successful surgeon at the moment are somebody who's too important to do emergency general surgery. And I think that needs to change. Now, that's going to involve engaging our senior surgeons. Now, I'm not saying that there aren't senior surgeons leading this, because there are senior surgeons driving this and with similar views. But ultimately, until this is perceived to be just as important as everything else we do, then we may be fighting a losing battle. We need to change structure. Now, I'm aware that I'm not in England at the moment, but in England, certainly, PBR guidance and the funding structures around emergency care are prohibitive. You know, any chief executive looking at putting this in place will, at the moment, say, okay, this is lovely for patients, but it's going to cost me £2 million. And that isn't the right foot to get off on when you're trying to start a new service. Finally, in terms of preparing for the future, generally, and this has been said before, I think we need to go from a culture where emergency surgery needs to be good enough, where our emergency surgery training needs to be good enough and we achieve competence, but there's no mention of achieving excellence within our syllabus at the moment for general surgery. I think we should establish emergency general surgical mentorship relationships between trainees as they go through and senior clinicians who value its importance. And ultimately, I think we need to provide training for a surgeon's whole career. When somebody comes out of the CCT and are employed by an institution, that institution needs to invest in that consultant's whole career, recognising that they can do different things at different times. So in terms of local workforce solutions, there have been many models of ambulatory care, of improving emergency laparotomy outcome, of delivering these things. And what that tells you is that there's not one-size-fits-all arrangement to be put in place here. You have to find local solutions. Emergency general specialty surgeons who don't do anything else, if that's the career people want and there's a need for it locally, especially if it's with major trauma, that's a rewarding career. I think that won't be necessarily the case for everybody, but I think we should look forward and say emergency general surgery with a subspecialty should become the norm. And you deliver different parts of the service at different times of your work plan. And that mix can change, as I've said. So in conclusion, the protocols and pathways part at the beginning of the Nuffield, to my mind, is not something we can ignore. There's clear patient benefits, there's clear efficiency benefits. We need to work out the finances, and we need to get our commissioners to understand that this is what we have to do. There is no yes or no to this. We do this or people die unnecessarily, and that's the simple bottom line. For the rest, there's some controversy. I think in terms of the other things, these are less important arguments, but in terms of EGS surgeons, my view is that we all need to be EGS surgeons and take it seriously. So I'd like to thank the team in Nottingham. I only inherited this from Mr. Neil Welsh, who's in the middle. He drove this for the last 3 years, and the management team in Nottingham. So thank you very much for listening. And yeah, I think it's a red hot poker rather than anything else. Okay. All right. So we're going to move on to a panel discussion at this point. So I'd like to invite Professor. We've got Rhiannon from ASIT, past president, just going out, and Mr. Nick Markham. So if there's any questions, please ask them. Or would it be a good idea for you to give your thoughts in turn, potentially?
I think Rhiannon might like to say something from the trainee's perspective, because it may not quite tally with the idealistic approach.
I think we've been quite vocal on the proposed changes fitting with shape of training, and particularly the RCS improving surgical trainings proposals that have been taking place over the last 12 months. I think me and Alex have sort of discussed about beforehand where we envisage from a trainee point of view. You've discussed the evidence from ASGBI survey that actually few trainees aspire to be pure EGS consultants. And I think very much the way that trainees envisage that they need to have some subspecialist interest alongside that. They need to have that EGS component actually valued, make some prestige to the career. I think that's very important, that we're not terming this as a sort of sub-consultant grade or reverting back to the old SR.
Alex, I thought it was a very good presentation. You rounded up very nicely what we said earlier on in the emergency general surgery debate. Completely agree with the suggestion. We do not want EGS to be considered a subspecialty. I'd say a couple of things. First of all, I think we've beat ourselves up an awful lot. I think we've come a long way in the last 5 or 8 years from where we were, which was you'd come to work, not realise you're on call, a full day elective work, and just fit in the acutes as and when. We've got the NELA, we've got a whole lot of the data now. I think we have come a long way. And the question to you would be, well, two things. The one slide that really struck home was the comparison of England versus New York. I mean, wildly different outcomes. Is that simply because they have got emergency general surgeons there? I mean, is it as simple as that, providing that service?
We don't know is the short answer to that. I mean, there are definitely some significant confounders and factors within that data. It's a fit population of patients of high socioeconomic status who are insured, point one. And those patients are delivered a service which is almost entirely attending-led from what we know of the data set. And of course that means that you wonder how they train anybody. But it's striking. But it's also important to see that it happens here. You know, a 6% mortality is achieved here. And I agree that we've come an awful long way. I mean, just in our local institution, as a junior registrar in Nottingham, to what's happening now is unrecognisable, and the quality we're delivering is incredibly different. But I think the message is accepted amongst all of us as surgeons now, so we need to recognise that and make it the standard of care. That's my view. But really the message isn't for us. The message is for commissioners in order to support these services. We're getting pushback in Nottingham at the moment financially about this, and commissioners are not working with us. They say they don't recognise the clinical benefits that we've employed. Now, that's why I'm worried about creeping back from what we've achieved if we don't get that side of it sorted out.
The question is, the college is considering running a programme of either training up from ST3 up to ST8 of EGS versus TIG-type jobs where you've got people coming off at C7, C8 to then go in and do a programme. From the training point of view, and from your recent experiences, would you go for either of those models, or do you think there needs to be an alternate model of training for EGS?
I think that would be in terms of training surgeons to be pure EGS surgeons, I think that fits best in a major trauma context, and those numbers are small. My personal view is that we all need to recognise that we're doing this, and we are. Everyone's delivering emergency surgery in some guise, apart from notable exceptions. And therefore, let's take it seriously and do it well. In terms of training, that's what we need to train for. And, you know, whatever the mechanism is that what comes out the other end needs to be a consultant who's expecting to provide emergency surgery as well as a subspecialty. And that is a career-long solution to a problem rather than a 5-year short-term solution.
Can I add to that? I mean, there are very easy things that could be done in training to increase the standard of emergency general surgical skills at CCT level. We've heard a lot about sort of modular training recently, and particularly some of the colleagues working with Wyn Lewis in Wales have presented results during the conference of 4-week pilot blocks of dedicated EGS coverage. So they are supernumerary. They are a second registrar on just purely for NC pod theatre Monday to Thursday, 12 hours a day. And actually, in a 4-week block, they achieved a median of 11 laparotomies. So it's easy to see that you could extrapolate that out to sort of a 9-month period, and you'd easily meet your indicative numbers for CCT. I think this major overhaul of increasing EGS any further than that is probably unnecessary for what you need to be competent at the end of CCT.
I completely agree with that, Rhiannon. I think that works really well with the mentorship angle as well, in terms of, locally in Nottingham, those kind of processes have been put in place in terms of core training. Maybe we should be thinking about them in terms of higher surgical training as well.
That needs buy-in from both trainers, deaneries, and also from the trusts to be able to dedicate that time.
Obviously, you know, it's symposia like this, you tend to be preaching to the converted. But as you can see, the bar has won out, suggesting that there's a fair degree of apathy in the subject. You know, yes, emergency surgery is 50% of our work, but it's amazing how often very few people seem to be that interested in it. You know, if we were having a meeting here about transanal TME, you'd probably have 100 people in the audience, because it's, you know, while they rarely ever do it, it seems more interesting, yet something that everybody should be, you know, is doing every day of the week, it doesn't seem to get that much interest. How can we raise the interest of this amongst the community out there? Because you know, every time we have meetings like this, we end up with the same size of audience. It just doesn't get people. They don't seem to understand it, or they're not that interested.
Show a slide showing what the proportion of medical legal cases come from EGS versus general surgery and GMC referrals. I mean, there's quite a disparity there. Heighten people's interest.
Well, that demonstrates that you need to get interested, otherwise you're going to be in coroner's court a lot, I guess. It needs a balance change. I mean, the last slides that I put up there, you know, as you absolutely say, we're fighting a battle against apathy, and we need big institutions to step up and say that's unacceptable.
We may be, I don't know, it's my yes, maybe the reason that there aren't more people here is that this isn't perhaps such the red-hot topic that I was expecting. I mean, I was thinking there would be some terrific controversy. I think we're all signed up to wanting to make EGS better. That has to be a given. And so I'm not sure it's apathy. I think it's just that it's actually not controversial, so people would rather be at the bar.
That's a fair point. What is controversial is the commissioning response.
It has to be sorted.
Do you think people would be more enthusiastic about embracing these changes and making the change in the hospital if they were able to hold on to a significant part of the funding that they have saved and plough it back into elective services or something in their own unit?
Absolutely. We negotiated a profit share agreement with our commissioners last year. They will not do the same this year.
Right.
I think it was Sarah Richards who was giving a talk earlier on about her ambulatory emergency surgical service in Bath, and she had managed to negotiate with her commissioners such that the reduced tariff that would normally be associated with doing some of the emergency work she did was actually being paid at the elective tariff. So it is possible to argue the case and negotiate such that you don't lose out. But the commissioning is a big issue, there's no question.
I asked her a question on that point and asked her how she did it, because we've had much more difficulty, it would appear, in negotiating a local tariff. When we first put this to our commissioners in order to proactively negotiate how we would fund this, we were told to go and do it, get the data, and then come back and then talk about the money afterwards. And this is a situation we find ourselves in, where a service where we've made excellent in progress is, we won't let it stop, but it is threatened by the funding arrangements that are in place in England.
If you have some questions, do you want to come up to a microphone so we can hear you, please?
Mr. Welsh, do you have a question?
I do, but there's no power on my light. So how do you get people interested in doing it? How do you make it important? Actually, you put the data out. So actually now we're getting subspecialized levels of consultant level data. We need to publish that in your appraisal folder for everything you do for the emergency take as well. I think every surgeon should have 2 bits to their thing, not just the bits they choose, the specialist bits, but also their outcomes, consultant level outcomes for their emergency work. And as soon as you start sticking that in front of people, there'll be the usual pattern of, first of all, the data isn't right, and it won't be to start with. Secondly, we need to make it right, but thirdly, it will drive the change and the level of importance. And it has to be seen, if you're a consultant doing 50% of the work as emergency general surgery, then 50% of the weight in your appraisal has to be dedicated to the emergency and revalidation to the emergency surgery.
I agree with that. Do you need comment on that, on the panel?
I didn't actually actually manage to hear it very well because the acoustics are not great.
So what you're saying is, in your annual appraisal, where up to now we're really appraised on our elective activity, but continue to do that, but also separately be appraised on your emergency outcomes.
The only question I was asked at my CCT RCP is, have I done 100 emergency laparotomies? And that was it.
Yeah.
If they all died,
If they all died, that's fine.
Any other questions from the floor?
My name is Andre, I'm from Southampton. I was just going to ask, you mentioned about having it as a separate subspecialty. What's the panel's thoughts on that subspecialty not necessarily being a surgical subspecialty or traditionally surgical subspecialty, and maybe being something like intensive care medicine, perioperative care medicine? We've had talks earlier in the afternoon about the need for improving our care of the elderly patients that we're operating on more and more now.
Was that asking if EGS should be separately in its own right?
No, not as a separate subspecialty in its own right, but having a subspecialty interest that isn't necessarily a surgical interest, such as colorectal surgery or upper GI surgery, but maybe one of the other subspecialties, such as intensive care medicine or a perioperative care medicine type model.
I mean, actually, we were talking about this earlier, and Andre highlighted the fact that now in Scotland they are dual accrediting in ITU and surgical specialties. I think there will be people who are interested in that. I'm not sure it would be a huge percentage, but you could see it would be a very interesting job for someone who has that kind of mindset to have offer both skills, and they would fit very well together.
I think that works in the context of level 1 major trauma centres.
Yeah. Yeah.
And there are trainees on such training programmes. We have a gentleman who's going for dual accreditation, emergency general surgery with major trauma and ITU, and there are people interested in employing him in a couple of years' time. So I think that is a model, but it's low numbers, isn't it?
Probably military interests, as you say.
Absolutely.
Yeah.
The military people would be good people to look at for that.
Careful to try and not create a single model and suggest that it would be applicable everywhere, because one size doesn't fit all. And I think I was invited here on the panel, because you might wonder why on earth I am here, to speak for the smaller DGH, which has very different pressures, but which still has to provide and wants to provide real high quality emergency surgery, and indeed elective too. One of the things that quite a few units are now doing is employing old codgers like me who will help to run the EGS service during the day. And so in my hospital we have 8 consultant surgeons, but a very small population relative to that, so perhaps only 180,000 or something. And the problem when you have 8 elective surgeons is that you don't really have enough work for them electively. But you do create a 1 in 8 rota, which in emergency terms is deemed reasonably satisfactory. So one of the solutions might be to employ more senior surgeons who are getting towards the end of their career, who wish to work doing an emergency shift, as it were, from 8 till 6 or whatever. And I know in Taunton, my colleague John Chester does that. My colleague Stephen Blair up in the Wirral, I think, is doing that now, and we are thinking of doing it as well, because it offers a solution which is only really right for the individual unit, but you wouldn't see that mentioned probably in a major work like the Nuffield report, because they tend to focus on the places which are bigger and don't have these special requirements.
I'd just actually like to follow up on that. David O'Reilly, I'm from Cardiff. We recently had a briefing from our deanery about the future of our trainees' placements. And we're all right in Cardiff, but it's been identified that at the smaller hospitals around South Wales, there aren't enough opportunities for trainees to do laparotomies to get their indicative numbers in those units. And consequently, in the context of reducing numbers of hire trainees, the hire trainees are going to be concentrated in Cardiff, in Swansea, a couple of other places, and they're not going to be out there in the small units. And I just wonder, from your perspective in a DGH, how you see yourself delivering an emergency general surgery service if that sort of thing happens to you when you don't have numbered trainees.
Do you want to answer that first then?
Obviously, I've been involved with working alongside Wyn Lewis on the sort of reconfiguration of how we deliver EGS modular training, and you're quite right that numbers of laparotomies to deliver enough for those sort of modular blocks would only be able to take place at the 3 major hospitals along the M4 corridor. That's not to say that the other institutes wouldn't be able to have general surgical trainees attached, but perhaps not for their EGS dedicated modules, so they would still be able to get their other competencies for their specialist interest.
But I think they'll have fewer trainees in those units.
Perhaps not necessary to. I think that the numbers they're talking about to accommodate would not necessarily take away from the other units per se.
So not every unit will be able to offer trainees the same complete depth or breadth of experience, and it may well be that in a hospital like ours, the exposure to emergency surgery for trainees is so relatively minimal that they wouldn't expect or accept that that's where they'd go for emergency training, but they would pick up lots of the other things that we hopefully could offer that would still be attractive and an important part of their ultimate armamentarium, if that's not the wrong word.
Yeah, because if you extrapolate out the numbers from that small sort of pilot study from a 4-week block to sort of 6 months, that would deliver roughly 66 laparotomies, so 2/3 of what you required for CCT. So you'd only be slotting out trainees into a 6-month block within those units, and it's only between Monday and Thursdays as well for that block.
Pete, can I ask you a question? How do you, no matter what you do, there are always going to be enthusiasts in anything, small groups of enthusiasts, but how can you stimulate enough enthusiasm out there to make the necessary changes to drive this forward on a national basis rather than pockets doing particularly well?
It comes down to how you stimulate the trainees in general. I think it goes right back to medical student times. You need to make sure you get people embraced and involved in these things from an early time. The worry we've got at the moment is how many FY1s, FY2s not seeing surgery at all. And that's going to have a massive effect on manpower. And I think just the simple thing of getting a med student into theatre, getting your house into theatre, showing them why it's fun, showing them what the crack is in theatre will make a big difference. The moment we run the risk of losing a whole population or a whole half generation of people coming through from med school who are not exposed to surgery like we were, I think it's a great shame. It doesn't take much to get them enthused.
But they're already going. Obviously, competition ratios dropped from 7:1 to 1.7:1 for general surgical ST3 over a 5-year period. So I think the crisis is already here.
Yeah, they're all going to psychiatry. They all come back pretty quickly, I tell you.
I can ask a question of Ian Anderson down there. Do you think the emergency surgery jobs that we see appearing around the country are truly attractive to make people want to do them, or do you think that some of these are just, created by their colleagues and the potential colleagues in the unit who don't really want to do the emergency work themselves and want to dump it onto somebody else?
I don't have hard data to answer that definitively, but I've heard of both models. I've heard of models that are undoubtedly dump jobs, a number of which haven't been filled or from which people have left very quickly, including one very high-profile EGS surgeon who was hunted to go to a job. I think people who do want to do it and who want to play a major role in it have got a great career ahead of them, but that's not going to cover the whole EGS rota. And I think, as we've heard from Alex, that there's still a mindset change needed. This is half our workload. and it's quite clear in England at least that the chief execs are driving who they appoint. They don't want the Royal College to come along and tick the job box. They've got they hold the budget, so they're going to tell you who they're going to appoint. And if the sad fact is that if the training system doesn't produce people of the right calibre to do it, they'll go to a different marketplace and appoint other people. And that would really undermine the training system. So we need to get the things all lined up better, and then the system will maybe begin to work better, I think.
Right, we need to move on. It's time for the presentation of prizes and the drinks reception. You have to get your priorities right. So thank you, Alex, for a very stimulating talk. Thank you for our panel, and thank you for the dedicated few who clearly aren't alcoholics and made it in here. So thank you. Thanks very much. Apologies for the